Hello, everyone. It is my pleasure to speak at this year's symposium on nurse-led initiatives in heart failure care. This is my disclosure slide. So today I'm going to talk about emerging opportunities for nurse interventions in heart failure care and unique strategies for remote patient monitoring and delivery of heart failure care in a virtual world. Heart failure is a significant public health issue in Canada, with an estimated 1 million Canadians that are currently living with heart failure. Heart failure is one of the most common causes of hospital admission in Canada, with more than 100,000 Canadians hospitalized each year. And it is associated with a long length of stay. The average is 10 days. The costs of caring for heart failure patients is high, and it is projected to increase. Heart failure is a complex clinical syndrome, with patients often having periods of stability, then decompensation, and requiring admission. It is a progressive condition and associated with an increased risk of mortality and morbidity. Many of these statistics highlight the need for continuing to develop novel approaches about how we can improve heart failure care in Canada. The consensus today is that interdisciplinary collaboration is the best approach to providing heart failure care. Collaborative care teams consist of cardiologists, heart failure specialists, nurses, nurse practitioners, primary care providers, dietitians, pharmacists, as well as other allied health disciplines. Heart failure care today is multifaceted, and it consists of providing personalized education on self-care management, the initiation and optimization of guideline-directed medical therapy, implantation of device therapy such as ICD and CRT, exercise such as cardiac rehab and nutritional programs, education on important lifestyle modification, managing common comorbidities that exist for heart failure patients such as diabetes and chronic kidney disease. And when disease advances, assessing patients for advanced heart failure therapy such as cardiac transplant and advanced care planning. So what might heart failure look like tomorrow? There is a need to shift specialty care from urban centers, hospitals, heart failure clinics to communities and the home. Nurses have a vital role to play in transforming the delivery of heart failure care in Canada. Emerging opportunities for nurses may include developing virtual nurse-led education clinics that are focused on providing personalized self-care management, enhancing the implementation of guideline-directed medical therapy through virtual medication titration clinics, and providing leadership in heart failure remote monitoring programs. The COVID-19 pandemic saw a rapid adoption of virtual care in programs and clinics across Canada through the use of telemedicine, video conferencing, as well as phone visits. Clinicians had to learn quickly how to assess heart failure patients and meet their care needs. Virtual care became mainstream because of the pandemic, but it is likely here to stay. Virtual care has the potential to improve accessibility of specialty care to remote and rural regions of Canada, as well as reduce healthcare costs and improve healthcare efficiencies. Additional benefits of virtual care include the convenience for patients and caregivers. So you think about reduced travel costs, time and ease to get to clinic visits, and this is especially true for patients who have mobility issues or are frail. Reduced exposure to infection. Virtual care may improve patient satisfaction, as well as lead to better engagement in chronic disease management. It also supports the involvement of caregivers at the time of healthcare interactions, as well as it provides an opportunity to up-titrate guideline-directed medical therapy in stable patients. Virtual care is not, however, without its limitations, and it is not for all patients. And some of those may include patients who are not comfortable with using this type of technology or have issues with accessing devices or internet services, patients who have hearing or cognitive impairment or a language barrier. There have been a number of clinical trials that have examined nurse-led interventions with respect to heart failure patient education and medication titration. Multiple centers and heart failure programs have adopted nurse practitioner or nurse-led medication titration clinics. And nurse-led clinics have demonstrated increased medication titration rates and achievement of target doses of guideline-directed medical therapy. In 2015, there was a Cochrane systematic review that looked at nurse-led titration of ACE inhibitors, beta blockers, and ARBs in patients with heart failure with reduced ejection fraction. 7 RCTs were reviewed, so just over a total of 1,600 participants, and the majority of these studies were from primary care or outpatient clinics. The main results were that participants in a nurse-led titration group had a lower rate of all-cause hospital admission, fewer admissions related to heart failure, and an increase in survival versus a usual care group. With respect to medication optimization, participants reached a maximal dose of beta blockers in half the time versus a usual care group. Largely in response to the COVID-19 pandemic, our program in 2020 implemented a nurse practitioner-led virtual heart failure medication titration clinic. And the goal for this clinic was to improve optimization of guideline-directed medical therapy and thereby patient outcomes, as well as reduce ambulatory clinic visits during the pandemic and manage patient volumes. Patients were referred to our clinic by their primary cardiologist for medication optimization, and 2 nurse practitioners, myself being one of them, would independently run a virtual clinic every 1 to 2 weeks, and we would provide virtual care through either OTN, telemedicine, or a phone visit. Our virtual visits would consist of assessment of a patient's heart failure symptoms and determining their functional class, review of data on a remote monitoring platform, such as their weight and blood pressure trends. If using OTN, we could perform a partial physical exam, so get a sense of someone's general appearance, whether they appear well or unwell, as well as the presence of any peripheral edema. We would prescribe, titrate, and monitor lab work for guideline-directed medical therapy, as well as provide advanced education on heart failure self-care. As well, identify patients who were not doing well and were in need of urgent or an in-person assessment. And we do have a nurse practitioner rapid heart failure assessment clinic in our program where we can see patients urgently and treat them with IV therapies in an effort to avoid hospital admissions. Following each of these visits, we would dictate a clinical note back to the MRP and the primary care providers. The majority of our virtual patients are enrolled in a remote monitoring program, and at our center, this is called Medley, which is an app that is downloaded to a smartphone, and patients input their blood pressure, heart rate, weight, and answer a few questions about their symptoms. Patients are provided with real-time feedback, and this is through an algorithm based on their readings and programmable targets. They are provided with instruction, for example, of when to take an extra dose of a diuretic. Clinicians can then review a patient's readings or trends on a main dashboard. So we can review their alerts for low or high weights, the frequency of a need for PRN diuretics, average blood pressures, and this is important when you are titrating drugs and you may want to screen for the presence of any episodes of hypotension, a patient's heart failure trend, and whether they are reporting any worsening heart failure symptoms. Many of our patients today also have wearables, so they are able to track their daily step counts, and we can use this in our assessment to gauge their activity tolerance. So are they living an active or sedentary lifestyle? As well, with the availability of home ECG tracings, if a patient is reporting palpitations or a possible arrhythmia, we can review an ECG tracing, consult as needed, and order any additional diagnostics. We also have a subset of our patients who have the CardioMEMS heart failure system. And this system is insertion of a pulmonary artery sensor to monitor ambulatory cardiac hemodynamics. Increases in pulmonary arterial pressures are an early indicator of worsening heart failure and precede weight gain or worsening heart failure symptoms. And through personalized pressure-guided assessment, if we start to see a patient has increased PA pressures, we will instruct patients to take an extra dose of a diuretic. And through using the CardioMEMS heart failure system, we have also optimized guideline-directed medical therapy. Guideline-directed medical therapy is often viewed as complex, and it consists of multiple drugs for at least. It's a gradual titration approach with follow-up of electrolytes and creatinine levels. So it can be time intensive and requires several visits in order to achieve optimal or maximally tolerated doses. And we know today that the current prescription rates for guideline-directed medical therapy are suboptimal, and this is likely due to a few reasons, such as clinician knowledge or comfort on prescribing these drugs, concerns regarding polypharmacy, as well as managing other comorbidities, clinical practice inertia, and also a patient's understanding or willingness to optimize therapy, particularly if they've been stable for a period of time. Guideline-directed medical therapy has proven mortality benefit in HFrEF patients. So we know that it reduces heart failure admissions, improves patient outcomes, as well as quality of life. Many of us are quite familiar with the CCS 2021 heart failure practice guidelines on the pharmacological management of HFrEF patients, with recommended starting doses for ARNI, beta blockers, MRA, SGL2 inhibitors, as well as specified target doses. The goal in our nurse practitioner virtual clinic is to titrate guideline-directed medical therapy every 2 to 4 weeks and achieve target or maximally tolerated doses within a time frame of 3 to 6 months. And once a patient has achieved this, they are discharged from our clinic. In addition to prescribing guideline-directed medical therapy, we also provide advanced education on heart failure self-care, so helping patients recognize worsening symptoms and then how to interpret that change in their symptoms. We know that medication non-adherence is a common issue for heart failure patients, with many patients not taking their medications as prescribed. And an important component of care is assessing for non-adherence and then seeking to understand, if it exists, what is the underlying cause? Is it intentional versus non-intentional? Implementing strategies to improve medication counseling, and as well assessing drug coverage. And lastly, it's extremely important to take the time to improve patients' understanding of the role of guideline-directed medical therapy and why heart failure drugs are titrated. So thus far in our nurse practitioner-led heart failure clinic, we have had about 30 patients enrolled. Anecdotal feedback from patients has thus far been very positive. So patients have told us that they find visits convenient, and this is especially true for patients we follow who live in remote or northern communities. Patients have indicated they've had improvement in their symptoms. We've had patients who have had improvement in their left ventricular ejection fraction, and overall satisfaction with nurse practitioner level care. A nurse practitioner-led heart failure medication titration clinic also supports full use of nurse practitioner scope of practice. And it is hopeful in the future that there will be an opportunity to study this type of clinic model and better understand and assess patient outcomes. In summary, virtual care is an emerging field which will likely continue to be integral to how heart failure care is delivered in Canada in the future. Virtual nursing visits are uniquely well suited to providing personalized education on heart failure self-care in a home setting with involvement of caregivers. Adoption of virtual nurse practitioner-led heart failure clinics can also support achieving optimal doses of guideline-directed medical therapy and thereby improving patient outcomes. Lastly, as virtual care continues to evolve, there is a need for ongoing research on how best care providers can deliver virtual care, as well as assessing patient and provider satisfaction with these models and patient outcomes. Thank you.